DRCR.net protocols. Over the last 2 decades, DRCR means Diabetic Retinopathy Clinical Research Retina Network. It has completed more than 30 multi-center studies in diabetic retinopathy in collaboration with more than 160 participating clinical sites throughout the United States and Canada, and have played a pivotal role in advancing the care of diabetic eye disease. So starting with the first protocol, the protocol A. So this study name is a pilot study of laser photocoagulation for diabetic macular edema, and this study was concluded on 31 January 2008. So in this study, actually the patients were having diabetic macular edema, and there were two groups. One group received MG photocoagulation, which means modified multi-spot grid photocoagulation, and another group received standard focal photocoagulation technique. And the study concluded that MMG was less effective at reducing OCT measured retinal thickening over 12 months and than the standard focal photocoagulation technique, which was modified from the ETDRS. Next is Protocol B, a randomized trial comparing intravitreal triamcinolone acetonide and laser photocoagulation for diabetic macular edema. So, the study concluded that over 2 years, the focal grid photocoagulation for center-involved diabetic macular edema was more effective and had fewer adverse effects than 1 mg or 4 mg dose of preservative-free intravitreal triamcinolone. So there were actually 3 groups. One group received focal grid photocoagulation, another group received 1 mg triamcinolone, and another group, the third group, received 4 mg triamcinolone. So the conclusion was that focal or grid photocoagulation was more effective for center-involved diabetic macular edema. Now, Protocol C, temporal variation in optical coherence tomography, measurements of retinal thickening in diabetic macular edema. So in this study, retinal thickening was measured from 8 am to 4 pm, and it was concluded that the thickening decreases slightly over the day. On average, the most eyes with DME have little meaningful change in OCT central subfield thickness or visual acuity between the hours of 8 am and 4 pm. So there was little change, and a change of more than 11% is likely to be real, but this was not in this case. And further, the CST was measured 6 times between 8 am and 4 pm, and the result was 6% decrease in CST during the day. Protocol D, evaluation of vitrectomy for diabetic macular edema study. So this study concluded that vitrectomy reduced retinal thickening in most eyes with diabetic macular edema, and also eyes with vitreomacular traction. But as the visual acuity improved by 10 or more letters in 38% of eyes, but also in addition to this, 22% of patients lost 10 or more letters after vitrectomy. So vitrectomy has good result in 38% of eyes and bad result in 22% of eyes. Protocol E, a study was done on triamcinolone, peribulbal triamcinolone for diabetic macular edema, and this study concluded that triamcinolone is unlikely to give benefit, whether it is alone given or given with focal photocoagulation. It is of no benefit to the patient having diabetic macular edema, and the patient having good visual acuity. So protocol A, observational study for development of diabetic macular edema following scatter laser photocoagulation. So there were two groups. In one group PRP was done in one sitting, and another group PRP was done in 4 sittings, and there was no meaningful difference found in OCT thickness in both these groups, and no meaningful difference in visual acuity between these two groups. So PRP can be done in 1 sitting, 2 sitting, 3 sitting, 4 sitting, according to the threshold of pain of the patient and according to the threshold of the doctor. The doctor can also become tired. So protocol G, subclinical diabetic macular edema study. So in this study, the patients selected were having subclinical DME, and about 1/4 and 1/2 of these patients progressed to more definite thickening, or they be judged to need treatment within next 2 years. Also, the results concluded that CST is greater in men than in women. Protocol H was a phase 2 evaluation of anti-VEGF therapy for diabetic macular edema, especially the bevacizumab or Avastin. This study result was that intravitreal bevacizumab can reduce DME in some eyes, but this preliminary study was not designed to definitively determine whether the treatment was beneficial. Protocol I, in which there was 2 groups. One group was having given intravitreal ranibizumab or triamcinolone in combination with laser photocoagulation for diabetic macular edema. So this study concluded that ranibizumab is more effective than focal grid laser. Also concluded that ranibizumab is more effective than intravitreal triamcinolone alone or in addition with laser photocoagulation for the treatment of centered involved DME. So ranibizumab is more effective than focal or grid laser, and also it is more effective than intravitreal triamcinolone. Also, this study concluded that focal grid laser treatment at the initiation of intravitreal ranibizumab is no better. So it may be possibly worse for vision outcomes than differing laser treatment. So differing laser treatment is good option. So laser treatment should be deferred for 24 weeks or more in eyes with center involved DME with vision impairment. Protocol J, the patient were having proliferative diabetic retinopathy and they were given intravitreal ranibizumab or triamcinolone as adjunctive treatment to pain retinal photocoagulation. So this study concluded that triamcinolone or ranibizumab in eyes receiving focal grid laser is associated with better visual acuity. So intravitreal triamcinolone is effective. Also intravitreal ranibizumab is effective for patients who are receiving focal grid laser for diabetic macular edema and proliferative and PRP. So laser for DME and PRP. Protocol K, the course of response to focal photocoagulation for diabetic macular edema. So this study concluded that focal and grid laser is having good results, and they reduce central involved diabetic macular edema, but not completely resolve it at 16 weeks. So focal grid laser photocoagulation reduce edema in 23 to 63% of patients, and the patients continue to improve without additional treatments. Protocol L, evaluation of visual acuity measurements in eyes with diabetic macular edema. This study concluded that autoref is worse than manual refraction. So manual refraction is good, and auto-ref is not a substitute for manual refraction to measure the visual acuity. So visual acuity should be measured manually in these patients, and with improved visual acuity outcome is a primary end point by checking it manually. Protocol M, the effects of diabetes education during retinal ophthalmology visits on diabetic control. So this study concluded that HbA1c level are not improved during personalized intervention at ophthalmology visits when HbA1c measurements and counseling about the importance of glycemic control in reducing diabetic complications. So during the visits they measured the HbA1c and they counseled the patients about glycemic control, but despite these efforts the HbA1c was not improved. Protocol N, evaluation of intravitreal ranibizumab for vitreous hemorrhage in patient having proliferative diabetic retinopathy. So in these patients, cumulative probability of vitrectomy was measured, and in ranibizumab it was 12%. 12% of ranibizumab group needed vitrectomy, and 17% of saline group needed vitrectomy. So there were two groups. One group received ranibizumab and another group received intravitreal saline. And recurrent vitreous hemorrhage during 16 weeks occurred in 6% in ranibizumab group and 17% in saline group. So the conclusion is that the vitrectomy rates are same in both of these groups, intravitreal ranibizumab and in saline group. They are almost the same. So the conclusion is that vitrectomy is needed in these patients whether ranibizumab is given or not. Protocol O, in this study time domain OCT was compared with spectral domain OCT and concluded that spectral domain OCT is best, and the convergence is possible between spectral domain and time domain. Protocol P, the patient were having central involved DME and they were having to undergo cataract surgery. So before cataract they were having central involved DME, and after cataract there was no substantial visual acuity loss or definitive worsening. Only small percentage of eyes experience substantial visual acuity loss. Protocol Q, this group patient also undergoing cataract surgery, and they were having non-center involved DME. In the previous study there was center involved DME, and this study there is non-center involved DME, and this study concluded that that after the surgery the non-center involved DME can exacerbate into centered involved DME. So the patients who are taking DME treatment for non-center involved DME, their non-center involved DME can exacerbate into centered involved DME. So it is advisable to receive anti-VEGF preoperatively or steroid injection perioperatively, and also advisable to control systemic factors. Protocol R, phase 2 evaluation of topical NSAIDs for eyes having non-center involved DME, and the conclusion was that topical Nepafenec and placebo drops are having the same results on OCT parameters or visual acuity in patient having non-center involved DME. Protocol S, two groups. One group received prompt PRP, another group received intravitreal ranibizumab with deferred PRP for patient having proliferative diabetic retinopathy. This study concluded that ranibizumab injection is effective alternative to PRP. Why? Because of 4 reasons. 1. In ranibizumab group, visual acuity outcomes are better. Also, they have less peripheral field loss. They have reduced rates of DME onset, and they have fewer eyes that underwent vitrectomy when they were followed for 2 years. Protocol T. In this group, 3 drugs were compared: aflibercept, bevacizumab, ranibizumab for diabetic macular edema, and found that in this study there were 2 groups. One was having better vision, 20/32 or 20/40. In this better vision group, all the drugs were having same results. In another group were having 20/50 or worse vision. In this group, aflibercept was better than bevacizumab, and aflibercept was also better than ranibizumab at 1 year, but at 2 years, aflibercept and ranibizumab were having same results. Protocol U. In this study, corticosteroids plus anti-VEGF were studied for persistent center-involved DME. So, in this study, the patient were having persistent DME. They have already received 6 anti-VEGFs, and after that, they received dexamethasone plus ranibizumab, and another group received sham plus ranibizumab. And the study concluded that DEXA plus Rani group have greater reduction of DME but no greater improvement in vision. Protocol V. In this group, the study were done on patients who have good visual acuity of 20/25 or better, and they have also diabetic macular edema. There were 3 groups. All the patients, one group received aflibercept, one group received focal grid laser, one group received observation, and there were no difference between all these groups at 2 years.